So my talk is the token non-neuro talk for the people in the audience who don't actually like neuro. It came to a neuro ICU day. So I'm going to talk about this concept of targeted temperature management, but focus on targeted temperature management in patients without brain injuries, which is probably a sphere, I guess, where it hasn't been used quite so much. And I'm actually going to begin by presenting some animal data, if I can work out which way around this thing goes. It goes this way around. No, that's not working. It advances it on here, but not on there. Oh yeah, there you go. That's a mouse. Who was it who made that noise? It's just a mouse. So I'm going to begin by talking about some animal data that actually are really where I started in this area, because I read this really interesting book written by this guy in the 70s all about fever biology, which has fantastic stories in it. And this mouse is one of the stories. So mice, you might not know this, but although they're warm-blooded, they can't actually mount fever without changing their behaviour. So if you're a mouse and you want to mount a fever, you have to go and bask in the sunshine and increase your activity levels so that your temperature goes up. And so if you put mice in an enclosure where the temperature is lower, then their ability to mount a fever is reduced. So if you take mice, and just for the person who made that noise, it wasn't this mouse, you inoculate their peritoneum with Klebsiella pneumoniae, and then control their ambient temperature so that they can't mount a fever, then the growth of the bacteria is 1,000,000-fold higher in the mice that can't mount a fever. So if you're a rattlesnake, the same thing applies. So rattlesnakes, they're cold-blooded, and so they truly mount fever by how they bask or just put themselves in the sunshine, and they change their behaviour in response to infection. Turns out that if you're a blue-gilled sunfish, you do the same thing. So if you're a blue-gilled sunfish who gets an infection, your body temperature goes up. If you're a pigeon, then it's a similar story, but pigeons actually have a normal resting body temperature of 41 degrees. And this normal resting body temperature of 41 degrees means that pigeons don't get pneumococcal pneumonia, right? Because pneumococcus is an exquisitely heat-sensitive organism, and so if you have it in the lab and you grow it in the lab at physiological body temperature, it grows, and if you heat the agar up to 41 degrees, it all just dies. And the same thing applies here if you're a pigeon. So if you inoculate the pigeon with Streptococcus pneumoniae, nothing happens unless you pluck all its feathers out, in which case its body temperature goes down and it succumbs to pneumococcal pneumonia. So, next one. This is my favourite one of all. This is the most interesting example of fever biology in all of nature, and it's highly relevant to intensive care medicine. Well, that last part's not true, but if you're honeybees and you're exposed to a fungus that only infects larvae, not adult bees, the whole behaviour of the hive changes in response to the exposure to that infection in the hive. So the adult bees all flap their wings harder so that the ambient temperature within the beehive rises, and the resistance of the beehive to this particular fungal infection depends on the total biomass of bees. So if you've got more bees, then they're more effective at raising the ambient temperature of the beehive, and that kills off the fungus. Isn't that clever? Yeah. Here's some bacteria growing in agar, and for the vast majority of human bacterial pathogens, the minimum inhibitory concentration of the antibiotics in the lab is lower if the agar is at physiological febrile range compared to if it's at a normal body temperature. So that suggests that actually antibiotics might be more effective in the presence of fever than in the absence of fever. And the idea of treating infectious diseases with fever is actually not new. So this man here, he's an Austrian man whose name is Julius Wagner Jauregg, and in 1927 he won the Nobel Prize for Physiology or Medicine for treating patients who'd been paralysed with neurosyphilis by inoculating them with malaria. It had been observed for many thousands of years by that time that some patients who had neurosyphilis and were paralysed had remission of their paralysis if they developed an illness where there was a fever. And so he reasoned that at that time there was no treatment for neurosyphilis, but you could treat malaria with quinine. So he reasoned that if you treat the patients, inoculate the patients with malaria, allow them to get a fever to cure their syphilis, and then treat them with quinine, that would work. And it did. So he managed to induce recovery in 1 in 3 patients that he treated with malaria. And that compared to a spontaneous remission rate of only 1 in 1,000 patients. And so that is a pretty remarkable thing that you've probably, guess you've been to one of my talks already, never heard of before. He also turned out to be a Nazi war criminal, and he thought that schizophrenia was caused by excessive masturbation and treated people with castration. So he wasn't all good. But it's interesting. This is another high-impact paper from JAMA, 1936, demonstrating the use of the Kettering hypertherm chamber. This is a patient who's in the Kettering hypertherm chamber, being heated up to 41.7 degrees. That's why there's this jug of water, in case it becomes overwhelmingly hot, to treat gonorrhea, which apparently worked. And now the rest of the talk's boring. So now, in response to that background data, we had a look at the relationship between temperature and outcome for intensive care patients, over 500,000 of them. And specifically, we looked at the highest temperature in the first 24 hours in intensive care and the risk of in-hospital death. And the first curve is one that's very similar to the one that Manoj showed you before, which is this U-shaped relationship. 1 represents the risk of death at a normal body temperature. Everything below the line is a lower risk of death, and everything above the line is a higher risk of death. And if you look at the no infection curve and the infection curve, I hope you can appreciate relatively easily that they are not the same. So in general terms, in the presence of infection, a higher temperature in the first 24 hours in intensive care was associated with a lower risk of death. Okay. And so this kind of supports the idea that fever might be good because it helps the body to fight infection. And it was really that idea that led us to do the heat study. And we were really exploring the idea that paracetamol, which we were giving to patients with fever and infection like lollies, might be causing harm. And so it was a phase 2B study where we compared intravenous paracetamol with placebo in ICU patients with fever and infection. And the idea was that, in fact, using paracetamol would make things worse, or it would reduce the number of days that people spent alive and free from requiring intensive care. So it was pretty pragmatic study. To get in, you need to have fever and likely infection, and you were excluded if there was a contraindication to paracetamol or if you had an acute brain pathology. You got paracetamol, 1 gram 6 hourly or a matched placebo, and you continued to receive that until either your fever went away, the antimicrobial therapy was ceased, that means you didn't have an infection anymore, you were discharged from the intensive care, you reached day 28, or you developed a contraindication to paracetamol. Now, all of those things are pretty simple, except for the resolution of fever. So the way that we did that was we gave everyone study drug until the morning of day 2, and then we asked the question, has the patient been afebrile for 24 hours? If the answer to that question was yes, we withheld the study drug. If a fever we then asked the question, is there a fever within the next 48 hours? If the answer to that was no, the study drug was then ceased permanently. If the answer was yes, then the study drug was restarted. We went back to assessing the patient daily, and if the patient was not afebrile for 24 hours, then they went this way and the study drug continued, so that the whole algorithm looked like that. Okay. There were 3,601 patients who met the inclusion criteria, of whom around half were excluded. 174 didn't consent. There were over 1,000 who were eligible but missed because of the availability of research staff or whatever. And 700 were randomised, around an equal number into the two groups. Most patients were analysed. There's 10 patients overall who withdrew consent. And the treatment groups were had similar baseline characteristics. They were people who were aged around the 60s. A lot of them had cancer, which is quite common in the sepsis population. Around 50% of them were ventilated, around 50% of them were on vasopressors. And similar to the data that Manoj presented before, we demonstrated that paracetamol was an effective antipyretic in the sense that it made your body temperature go down. Our sample size was bigger, and so we showed that that was a statistically significant reduction, which actually turned out to be a statistically significant reduction in body temperature of 0.3 of a degree, which is not very much. Very similar for mean body temperature. And the primary outcome, as I mentioned before, was the number of days that people spent alive and free from needing intensive care. And there was no difference. Numerically, in fact, though, the patients in the paracetamol group spent a higher number of days alive and free from needing intensive care than the patients in the placebo group. And as you can see here, this is a p-value that's not too far away from 0.05. There's the distribution, and I guess with the eye of faith you could say there's a few less dead people here and a few more people up here who spent a larger number of days free of ICU in the paracetamol group. And in fact, when you really teased it out, it looked like something kind of happened, which is that the ICU length of stay for people who died was more than twice as long if they were allocated to placebo, and the ICU length of stay was nearly a day less for people who survived who were allocated to placebo. So it seemed like paracetamol sped up your recovery if you were destined to survive and delayed your death if you were destined to die. But it didn't make any difference to your overall mortality rate. So that doesn't really tell you what to do, because you can't tell whether the patients are going to die or not necessarily. But it does suggest something's happening. And it doesn't seem to be the thing that you'd expect to be happening if the hypothesis that I put to you at the beginning was right. Because it actually looks like, if anything, the group who had their fever treated maybe did a little bit better than the group who didn't. So we concluded that paracetamol didn't alter the number of ICU-free days, that it didn't have much of an effect on your body temperature, and that it was well tolerated. In fact, I didn't present the data up there, but it turned out that people stopped placebo more frequently than paracetamol because of the development of liver dysfunction, which is kind of interesting. Now, the thing though that kind of I was left with at the end of the study was this idea that maybe, just maybe, we had it the wrong way around. Maybe fever's actually bad some of the time. So this is a true statement. Fever does increase metabolic and physiological demands. And this is also a true statement. So if an illness is reversible, intensive care therapy allows patients to survive if they can be kept alive long enough to recover. Yeah? That's a truism. And fever is common. And if you're really sick, being supported near the limits of what we can offer in the intensive care, then it sort of stands to reason that your ability to tolerate fever might not be that great. So maybe one way of protecting patients from the physiological demands of fever is to systematically prevent it and treat it. Okay? And it turns out that if you look at the literature, this is a position that is supported by some other studies. So this is a study, the Sepsis study from the American Journal of Respiratory and Critical Care Medicine, where they took patients who had septic shock, who were mechanically ventilated and sedated, and randomised them to cooling to normothermia versus no cooling. And I put a red box around this bit because this is the statistically significant finding, which is at day 14, the mortality rate was lower in the patients who were assigned to cooling to normothermia. And by the time of ICU discharge and hospital discharge, that effect had gone away. So in the paper they say physical cooling to normothermia reduces early mortality. You could also say physical cooling to normothermia delays inevitable death. Yeah, that's another way of saying the same thing. And actually, that finding is strikingly similar to the finding that I presented in relation to the heat study, right? Which is that the patients who were destined to die took longer to die. And the patients who were destined to get better got better more quickly. There's another study which looks at ibuprofen where they had a big separation in temperature, and it's a small study, but the point estimates again favoured the ibuprofen group. This was a sick group of patients. And so this is the idea that I have in my mind now. Risks and benefits, least sick patients, most sick patients. And then we'll just draw a random line and say that there are potential benefits related to fever. Now, these potential benefits might not actually be linear across the illness severity spectrum, but for the sake of simplicity, let's just pretend that they are. And then on the basis of what I've just said, which is that if you're really, really sick and being supported near the limits of what we can offer, then reducing fever might actually allow us to keep you alive long enough for you to get better. It seems fair enough to put a line that looks like this. So if you're really, really sick, fever has a substantial cost because it has a physiological burden or a physiological demand that you might not be able to meet if you're really, really unwell. If there's absolutely nothing wrong with you at all and you're at home with a cold, then actually there might not be too much of a cost to having a fever, and the benefits might conceivably outweigh the risks. And perhaps what happened in the heat study is that the patient population that we recruited was around here, where the benefits and the risks balance each other out. And so I have this idea that there is a population of patients who do not have neurological injury, who are really unwell, who are only just able to keep alive, where actually if you systematically prevent and treat fever, then you might make a dramatic difference to whether or not those patients live or die. Now, I just made that up and it might not be true, but it is something that I would like to test. The idea that up here, the costs of fever exceed the benefits and fever should be treated aggressively. Now, the other thing is that I mentioned before that there's this relationship between the presence and absence of infection and outcome. And that's a reproducible relationship which is consistent with what we know about animal biology, and it would be stupid to ignore it. So what I'm going to say is that if you've got an infection, the line goes up, and if you don't have an infection, the line goes down. All right? So I reckon that makes sense because it seems likely, on the basis of all the stuff that I presented before, that the presence or absence of infection may well make a difference to where the benefits are. Okay. So I'm working on a program of research to try and help evaluate this question, and at this stage we're doing a feasibility study which is looking at active control of temperature versus ordinary temperature management. And because it's a feasibility study, I probably don't have it right yet, and it may need to be changed, but I've presented to you the basic concept that I'm trying to investigate and that I hope I will be able to investigate in time. It's a multi-centre study, it's open label, and it compares prophylactic intravenous paracetamol and early targeted physical cooling to treat fever with standard temperature management. So the prophylactic intravenous paracetamol is there because something happened in the heat study when we gave people paracetamol, and early physical cooling is there because something happened in the sepsis cool study. So we're looking at mechanically ventilated patients without acute brain pathologies who are expected to stay ventilated the day after tomorrow. This population of patients has a mortality rate of around about 30%. There's the specific eligibility criteria right there. Acute brain pathologies are excluded, and that includes patients with potential hypoxic ischemic encephalopathy. The standard care arm get standard care. We're trying to avoid administration of strict regular intravenous paracetamol to those patients on the basis that in most places that isn't standard care. And we have a fever treatment algorithm that looks like this. Basically, the idea is that when people breach a low threshold for what constitutes a fever, so a core body temperature of 37.8 degrees, that they get simple physical cooling measures, and then as soon as they reach 38 degrees, they get strict normothermia with a physical cooling device. We're aiming to demonstrate that we can make the body temperature lower and assessing some other aspects of feasibility so that hopefully we can test this hypothesis in a larger trial. We're going to collect some things that we could conceivably use in a larger trial. It's 184 patients and one got enrolled today. So now we've got 17 patients. So I guess we're almost 10% of the way there. And here's some take-home messages. This I haven't touched on at all in the talk, but one of the things that I think we now know is that the various different methods of measuring temperature are not all the same. If you want to know what the body temperature is, you should monitor the core temperature continuously. People can die from high fever. And I think the idea that TTM might benefit patients with inflammation and sepsis who have limited physiological reserves is logical, and it might be true. And I think especially in the absence of sepsis, it is entirely plausible that the people who are really sick will benefit from systematic control of body temperature, and I think that's a reasonable treatment to apply. That's me. And if you're on Twitter and you want to see what's happening in the reactor trial, you can look at that hashtag. And that's it. It's all neuro from now on.